Working in the Jinwoo National University Hospital, he is also quite famous interventional oncologist. Till now, he is also still a member of the CSGI and also the upgrade reviewer of the SIR. Today, this show will talk about the radio evaluation in Asian HCC management. Let's welcome Professor Choi.
Thank you for your kind introduction, and also thank you for having me here in this beautiful city of beautiful country. So I'd like to talk about radio evaluation in Asian HCC management. These are my disclosure. And I'd like to start my talk with some imaginary, but a very common conversation between Western and Asian interventional radiologists regarding Y90 radio evaluation. So Asian doctors, Asian hematologists, and surgeons have a common idea of Y90, which is Y90 is too expensive for Asian practice, and early data about Y90 failed to show superiority over case. Western doctors usually want to start their talk with radiation segmentectomy, which means, as Dr. Choi introduced, is radio embolization of 1 or 2 tumor-bearing segment with very high dose of, also relative dose of Y90. So they want to start this talk with radiation segmentectomy. So radiation segmentectomy is potentially curative. Then Asian doctors respond, we have enough experience in percutaneous ablation, but over-expensive radiation segmentectomy has no rules in Asia. Then Western doctors say, personalized dosimetry. It is a new chapter, so we can treat more advanced tumors better than before. The Asian doctor says we have super-selective tests. Super-selective tests effectively treat the patients even before radio embolization. Follow-up question: when do you consider Y90 in Asia in your practice? This is a typical question when we have no other choice for Y90. And also typical response. But we always have a good choice. We have super selective taste, we can do taste plus RT, taste plus chemo infusion, we have a lot of options, so we always have a good choice. So this is the repetitive loop of conversation that I have experienced for the last decade. But now some doctors in Asia start to realize that Y90 is a new tool to address unmet needs in HCC management. So I'd like to talk about how to use or when we have to use Y90 instead of super-selective tests. This is my graphical outline or indication that we have to, or we'd rather use Y90 than other treatments. So let's start from the early HCC. Early HCC, Y90 is now included in VSIR 2022 as a second line treatment when the tumor is less than 8 centimeter. The key study is the legacy study, which retrospectively includes single HCC less than 8 centimeter. And when you look at this waterfall plot on the left side, each bar means each patient, and the green bar means the patient showed minus 100% tumor size change, which means the patient showed complete response. So when you look at this left side waterfall plot, most patients showed complete response. Also, when you look at this right side Kaplan-Meier curve, especially this dark green line showing local tumor progression after treatment, there's almost 0% of local tumor progression. So high dose of radio embolization for single tumor is curative. And then we have a prospective study for HCC with unfavorable location of ablation. So the 2-year local progression rate is almost about 10%, still very low, and this study confirmed that radiation segmentectomy is potentially curative. We don't have published data from Asia yet, but recently we analyzed our institutional data for HCC within blood criteria. So here within blood criteria means I have some patients with multiple tumors. Although I have some patients with multiple tumors, the waterfall plot was surprisingly similar to that of a legacy study. And this was a very little local tumor progression rate. So the message from this comparison is radiation segmentectomy is very reproducible when it comes to technique and when it comes to outcomes. So in aggregate, I don't mean, I'm not saying that RFA should be replaced by radiation segmentectomy, but we have to think about tumor location when we treat early HCC. So there is a very central or pericardial area that we can't ablate because of the risk of central cardiac injury. And then we have easy ablation too. So when tumor is located here in the region, we have to ablate this tumor regarding the amount and the level of evidence regarding percutaneous ablation. The tumor is here, is visible and approachable, so there's no reason to avoid percutaneous ablation. And then we have this or subcapsular area. I like to say this is ablation with maneuver. You can ablate the tumor when it is in this yellow zone, or we need some kind of maneuver like artificial size, fusion imaging, and in extreme cases we may need a laparoscopy assisted. So this means this is not an easy case for ablationist, and this is difficult, and the outcome depends on the level or skill of operators. In other words, the outcome is less reproducible. But for potential-based person like me, subcapsular tumor is one of the easiest tumor location that I can treat with transarterial approach. So the question is, how do we treat the patient and the HCC in the yellow zone? Do you want to treat the tumor with the most difficult ablation technique, or you want to treat the easiest technique of transarterial approach? So I like to say this yellow zone is ablation with the maneuver zone, or this can be a radiation zone. And let's also think about the pericardial area. We can't ablate the tumor in the red zone, but we can treat the tumor with a radiation. Once the tumor is hypervascular, we can deliver enough yttrium into the tumor while minimally damaging to the affected lobe. 4 centimeter HCC subcapsular area is not easy to completely treat this tumor with percutaneous ablation. The cannulation of these two arteries is very easy. Even my fellow can do this, and the outcome is very reproducible. Another case, 2 centimeter HCC, now in case by the left bile duct. So my hospital ablation is refused to treat this patient. But I can treat this patient with a radiation segmentectomy with a reduced dose because I don't want to make any severe damage to the left bile duct. 1 year later, the patient showed a mild bile duct dilatation, but there is no hypobilirubinemia, no symptom, tumor shows CR. So this is how we use radiation embolization when early HCC is invisible or percutaneous ablation. Let's move on to the intermediate HCC. This is a very heterogeneous group, so there were many different scenarios can involved in this intermediate HCC. Let's think about this case. Bilobar disseminated HCC. So liver function is good. The left lobe is completely replaced by infiltrated HCC, and right lobe tumor, right lobe is multilateral HCC. Our past approach was CTAs for both lobe and additional radiography for the left lobe. And then the typical scenario that we can see is patients almost always suffer from severe post-embolization syndrome, which substantially decreases patient's quality of life and also delays subsequent treatment like system treatment. And now, with Y90 radiation only for the left lobe, because left lobe is completely replaced by tumor now, we can assume that there may be minimal damage to the liver function if we ablate the whole left lobe. So with Y90 only for the left lobe, and start the checkpoint inhibitor within 1 or 2 weeks. So regarding oncology outcome, I'm not sure the second approach is better than the previous approach because we don't have enough data yet, but I'm pretty sure that the quality of life of the second approach is way better than the first approach. So this is how we apply wide gradient variation for patients with widely or disseminated HCC. Next situation that I want to talk about, the localized but sub-aggressive tumors. Localized multinodular, localized infiltrative, or localized but taste-resistant HCC. In these cases, we can do very high dose to the affected segment. So this is expensive approach, but we can make a way better outcome compared to the taste or other localization treatments. So let's see this patient. This patient is cold internal tumor. We treat this patient with conventional taste twice, and also add external therapy for 6 months. Although we made our best effort for 6 months, there's still viable tumor. So the half of the tumor is died completely. There are mixed viable and non-viable cells in the remaining half of the tumor. This is the result of our best effort for the initial 6 months. So we switch to radiation irradiation. So my approach in this case is not to calibrate the teeny tiny tumor either super selectively, but to kill every cell in and around the tumor. This is the result of the patient's completely response for almost 3 years. I'd like to move on to the large HCC, especially large tumor, BC 8 centimeter. And I don't think BCLC well reflects the nature of large HCC, because large single HCC is BCLC 8, but even if there's very small satellite nodule, it becomes BCLC B. And as tumor grows, the nodules are conglomerated, and then the stage becomes BCLC A again. And when it comes to treatment, ablation is impossible. Transplantation is highly limited. Then we have resection and taste. Resection is not consistently easy for these patients with large HCC, especially getting enough margin for large tumor, compressing the hepatic vein and portal vein is not easy. So then the patient usually receives the conventional or adaptase, which is widely available. Well, think about the typical scenario of typical course of patient after taste. First, the patient suffers from severe post-embolism syndrome, which delays the subsequent treatment, and almost always the patient needs a subsequent taste. And then for the second and third taste, there are many extrahepatic correctors. We can't treat every extrahepatic corrector. So the patient never experiences complete response. And we have already irradiation, but for now is recommended only for tumor less than 8 centimeter because we don't have enough data for HCC larger than 8 centimeter. In this case, in Korea, we usually apply very high dose radiation irradiation, and we recently analyzed our institutional data. So when liver function is good, and we can have enough future liver remnant, which means untreated liver segment after radiation irradiation, then we give a very high dose of YNA into the tumor and surrounding the liver. The outcome was good. First, our CR rate at 36%, objective response rate at 92%, 5-year survival 83%. But most of all, I'd like to emphasize the duration of response was 22 months, which means the patient was in PR or CR state for the initial almost 2 years. And think about the quality of life for the 2 years and compare this with the quality of life of patients who treated by conventional tests or DAP tests. This is one of the typical scenario, large hypervascular HCC, and we check we predict the outcome of Y90 radiation irradiation by injecting technetium tech MAA, and we guess, well, this is good indication for Y90 radiation irradiation, and we deliver very high dose of Y90. And the day after treatment, the patient is discharged after PET scan without any discomfort, any complication. And 6 months later, tumor shows no, the MRI shows no viral tumor, and left lobe hypertrophied, and our surgeon conducted a right lobectomy as a definite treatment, and pathology showed complete pathologic necrosis. So to be honest, I can't make this result for every patient with large HCC, but I'd like to say this is a very common scenario after radiation of large HCC. Let's move on to my last scenario, which is advanced HCC. This is also a very heterogeneous group, but I'd like to focus on unilobar HCC with unilobar puberty. So my question is there a role of ablative radiation or high-dose radiation with unilobar HCC with, if you want to treat, or in other words, unilobar PVT and channel A patients? So this is one of my favorite cases. The patient had a small tumor, 1.6 centimeter tumor, and the patient underwent radiofrequency ablation in outside hospital. 5 months later, there's total tumor thrombosis, and the patient was recommended to receive radiotherapy outside hospital. And the patient is so mad because before treating this tumor, the doctor said it's a curative situation. So we can cure your HCC now. And then 5 months later, there's a tumor spread in your tumor segment, and you analyze it, and there's no choice of external radiotherapy. So the patient is so mad and came to my hospital. And we did some workup, and we realized that this tumor is very hypervascular, and if we inject Y90 into the tumor segment, or Y90 will be captured, very well captured in the tumor thrombosis. So we delivered a very high dose to the right anterior section to kill every cells in the right anterior section. Not only the tumor cells, but also surrounding liver cells and connective tissue, every cells in the right anterior section. And then the patient showed a complete response, which lasts almost 2 years. So this is my summary slide. I'd like to summarize our approach for our position to Y90 radiation with this graph, with x-axis representing tumor burden from small to large tumor and finally vascular invasion, and with the y-axis representing treatment intention for palliative to curative. And this is our past approach for so for HCC smaller than 3 centimeter, we have RFA and microwave operation as the only 2 curative option. And Z-case was backup for this early HCC. And as tumor size increases, the intention becomes from curative to palliative, and we have Z-case and DAP-case. Now, we have a Y90 radiation as the most curative option with very wide spectrum. So for early HCC, RFA microwave radiation is still the treatment of choice. But was it impossible or infeasible? Y90 radiation is the best alternative. And for larger tumor, for HCC larger than 3 centimeter, radiation provides the most curative option. And now we have Z-case and DAP-case as a relatively palliative option. Thank you for your attention.